Thank you all for joining today. I hope you had a chance to see the shout outs that many were submitted. I want to give my own shout out. A lot of them were thanking our healthcare teams, and I second that. It's been a really long couple years for the healthcare teams, and we really appreciate all they're doing. Today, our goal is to actually reach out to some of your families and give you some of the information that you might find helpful as you're trying to navigate this next phase of the COVID-19 pandemic. We're going to start. Dan Diekema is joining me. Dan is our hospital epidemiologist. He's an infectious disease specialist. And I'm Pat Winokur. I'm the executive dean in the College of Medicine here. I'm also an infectious disease specialist. And so we are combining our skills to help answer your questions the best we can. And Dan's going to start by just showing some slides that I think are really helpful for kind of orienting everybody to what's happening today with this new kind of surge of the Omicron variant of COVID-19. So Dan, I'll let you share your slides.
Thank you very much, Pat. Very happy to be here. And as you just said, we'll go through some sort of a basic update of what's going on with COVID-19, a little bit from around the country and then in Iowa, really focusing on this new variant called Omicron. As many of you know, all viruses, when they replicate, they change over time. And sometimes they change enough that we call that strain of virus a new variant. And we've been dealing with multiple variants, it seems, with COVID-19. And the most recent one is this one that is called Omicron. So what do we know about this variant? Well, we know that, unfortunately, immunity, our immune response to previous infection and prior vaccination is somewhat less effective at preventing infection due to the Omicron variant than to prior variants. However, and it's important to note that the vaccine still protects us, especially against getting severe disease or needing to be hospitalized from COVID-19. Another thing we know about Omicron is that it is the most transmissible variant that we have seen yet. It also has a shorter incubation period, meaning a shorter time from when you're exposed to when you develop symptoms of COVID-19. Because of these two things, it spreads faster than any of the prior variants, as you'll see in a moment. And so it's currently causing the highest case rates that we've ever seen during the pandemic. If there's any silver lining, it's that Omicron causes somewhat less severe disease, particularly than the Delta variant that just came through, and is less likely to cause people to be hospitalized. However, as you'll see, hospitalizations are increasing largely because of the sheer number of cases. So even if a small percent of people who are affected by COVID-19 need to be hospitalized, if the number of people affected is high enough, it can still fill up our hospitals. And then importantly, as many of you know, it can lead to staffing shortages because our healthcare personnel, our valuable staff get sick themselves or family members get sick, so they cannot come to work. So that exacerbates or worsens the problems with hospitals that remain very busy providing care. So where are we nationwide with COVID-19? Well, these are graphs that are taken, they're publicly available. You've probably seen them on the New York Times website. On the upper left is a graph of new reported cases by day in the United States through the entire pandemic, from February of 2020 until today. And one of the things that I want you to note is that we are now at case rates that are 3 to 4 times higher than we've ever seen in the pandemic. Notably, though, we may be reaching a peak here in the US with the overall number of cases and started to come down. A little bit of caution here because of the long weekend last weekend, there were some reporting delays. So we'll see if this trend continues. But many of the places that Omicron hit early, the states in the Northeast, many of them with very high vaccination rates, are already seeing their case rates come down. Other parts of the country, like Iowa, are still seeing their case rates go up. And then on the right here is a graph of the total number of people hospitalized in the United States. And you can see that unfortunately, we also are at the highest number ever hospitalized for COVID-19 prior in the pandemic. Now, proportionally, we're not 3 to 4 times higher than we've been before. But again, just the sheer number of people infected has led to about 150,000 people in the US hospitalized with COVID-19. So how do things look in the state of Iowa? Well, unfortunately, we also are seeing the highest case rates we've ever seen during the pandemic. Over 5,000 new cases reported per day in the state of Iowa. And in terms of hospitalizations, we have not yet reached the peak that we saw back in November and December of last year, or not of last year, of 2020. But we are continuing to increase, and we're at about 1,000 Iowans hospitalized with COVID-19 over the last few days in the state of Iowa, and about 200 new hospitalizations per day. And how do we know this is all due to Omicron? Well, it's because we at the university and in many other, and everywhere really in different parts of the country, submit samples from individuals who have tested positive for COVID-19 to our state laboratory, and they do gene sequencing and can tell us whether a virus is the Omicron variant or the Delta variant. And you can see in all these regions of the country, these pie charts, the purple is Omicron, the orange represents the Delta variant. And if you looked at this map just 4 or 5 weeks ago, all of these circles would be mostly orange. So you can see that in very short order, the Omicron variant in purple here has really taken over across the US, just as it has in countries around the world. So one of the things that I want to emphasize just here at the beginning is how protective the vaccines remain, even though the Omicron variant has some ability to evade immunity from prior vaccination. These vaccines remain very effective. So I'm going to show you some data from New York State. And you can see here, I know the numbers are quite small, but this goes May through December and January. And Omicron hit New York here in early December is when you started to see the impact of Omicron. And on the left here are cases per 100,000 population. The rate of cases per 100,000 in the fully vaccinated is in red. And you can see here that it did increase, but it increased, much, much less than the case rate among those who are unvaccinated. In fact, the case rate among those who are unvaccinated was around 8-fold higher at its peak than the case rate among the fully vaccinated. This leads to a vaccine effectiveness against infection or new cases of somewhere between 70 and 80%. So really very good protection, even though the Omicron variant is the best variant we've seen at evading vaccines. The other good news from this slide is you can see that in New York State, the case rates have begun to come down. Now, the next slide I'm going to show you looks very similar, but this slide is for hospital admissions. And here the protection of the vaccines is even more impressive. You can see here again, daily hospitalizations per 100,000. And the red line here are hospitalizations among the fully vaccinated. The blue line are hospitalizations among the unvaccinated. And here you see about a 10-fold increased risk of hospitalization among the unvaccinated, with an estimated vaccine effectiveness on the right side here of around 90%. So very impressive protection. But I also want to emphasize not just the importance of being fully vaccinated, which the CDC defines as receiving 2 doses, for example, of the Pfizer or Moderna vaccine, or 1 dose of the J&J vaccine, but even more so the importance of getting that booster dose if you're eligible, meaning if it's been over 5 months since you've received your vaccine, if it's a Pfizer or Moderna, or more than 2 months since the J&J vaccine. These are data from Southern California, Kaiser Permanente, thousands of patients that they examined during the Delta and the Omicron waves. They were able to tell whether someone was infected with Delta or Omicron and calculate the effectiveness of the vaccine at preventing hospital admission. And so what you can see here is that the 2-dose vaccine was giving protection against hospitalization somewhere in the high 60s or 70% range. Not bad, but not as high as what was seen with Delta. But if you had received that booster dose, you bump that protection up to around 90% protection against hospitalization. So these data from the parts of the United States that have already seen Omicron longer than we have really show the value of getting vaccinated and getting that booster dose. And we do have a long way to go in the US. We are unfortunately really falling behind worldwide in terms of full vaccination rate and also booster dose rate. And what I'm showing you here are the percent fully vaccinated by age group from the Iowa Department of Public Health website. And what you can see here is that if you look particularly at those under the age of 30, fewer than half have been fully vaccinated. And then the 5 to 11-year-old age group, as you know, have not had as much time with the vaccine available, but still very low vaccination rates to this point. And the booster dose rates are even lower than this. And so it's no coincidence, I think, that we're also seeing the highest proportion of new positive tests in these younger age groups that tend to be less likely to be vaccinated. So finally, how do we respond to this Omicron surge? What can we do to protect ourselves? Well, obviously, I'm going to tell you to get vaccinated based upon the information that I just showed you. Get that booster dose if you qualify. Encourage all of your family members and friends who are not vaccinated to be vaccinated. And then continue the other layered approaches that we've talked about from the beginning that can prevent transmission of this virus. Masks do work. And I think we're in a phase right now, given how transmissible Omicron is, of trying to increase or up our mask game, so to speak. If you're wearing a cloth mask, consider moving to a medical mask, a KN95. And I believe that part of the federal plan is to send N95s to and distribute them widely to the public if you wish to wear one. So moving to the best mask that fits you well and that you can wear when you're out in public. Continue practicing good distancing, hand hygiene, avoiding crowded public indoor spaces. And if you're sick, importantly, stay home until you can get tested. So this is often what you've probably seen referred to as the Swiss cheese model of prevention. And what that means simply is that each one of these layers of prevention has holes in it. It's not perfect. You can still get infected if you're wearing a loose-fitting mask in a crowded public space, for example. But if you practice all of them, your chance of getting COVID-19 is greatly, greatly reduced. So I think that that's all the slides I have, at which point we're happy to take your questions.
Yeah, so I have a series of questions that people have submitted. I hope that what Dan showed gives people kind of a baseline, and we have some great questions that have already been submitted, but if you have additional questions, please submit. First question I have is, I've heard many people who test negative with a home test and then test positive with a test from a clinic. Can you explain this? Dan, you've worked in the clinical microbiology laboratory, so this is a great question for you.
Yeah, it's a very good question. And it really is one that more and more people are asking because a lot of people have noticed this phenomenon. And we don't know yet if this is more characteristic of Omicron than prior variants, but it's becoming quite clear that during the first 2 to 3 days of symptoms from COVID-19, the home antigen test can be negative. And so if you have a negative antigen test, the rapid at-home test like the Binax now, and you have symptoms that could be COVID-19, you should not consider yourself not to have COVID-19. You have two options at that point. You can get a PCR test, which are the ones done in the clinic and at the hospital that are more sensitive and will be more likely to be positive during early symptoms. Or you can repeat that antigen test at least 24 hours later, possibly even a couple of days later, and in the meantime, continue to isolate. So many people, I think, choose the first because as long as PCR testing is readily available, which we're working hard to continue to make it readily available to you, that gives you an answer faster. So symptoms and a negative home antigen test, let us, give us a call and arrange, or go through my chart and arrange for a PCR test.
Great, thank you. If I test now, how do I know what variant I have? And do all tests show the variant?
Another good question. And if there's another silver lining about Omicron, it's that it doesn't seem to evade our diagnostic tests. So the tests we're currently using, including the antigen tests, will detect the Omicron variant. Now, the tests that we're doing in the laboratory, at the hospital, in the clinic, and your home test will not tell you if it's Delta or Omicron. We currently are finding that out by sending these samples to the state lab where they're doing sequencing, although we are bringing up some of that sequencing in our lab. But the fact is that right now, Omicron is basically every virus we're sequencing. So if you get COVID-19 right now in Iowa, you have Omicron. And so it will not make a difference in terms of your therapy, whether you have Omicron or might be one of the 0.01% of people who has the Delta variant.
Great. It appears that a vaccine only helps protect you from worsening symptoms and infection from COVID-19. So why is there this understanding that everyone should be vaccinated? I'll take that one. I've done a lot of the vaccine trials work and have seen a lot of the data. And though we are seeing people that are breaking through, and there are people who have been fully vaccinated that are getting Omicron, it is many fewer than would be getting sick if they had not been vaccinated. And Dan showed you that this vaccine is still really effective at preventing infections. It is really effective at preventing hospitalizations. And the other thing, remember, when you're getting vaccinated, you're helping prevent spread to other people. You may have a family member who is immunocompromised. You are helping protect that person. Maybe you have a child who's under the age of 5 and hasn't been able to get the vaccine. By getting the vaccine, you're helping protect your child. Those are really important features. We know too that the virus is particularly transmissible. This vaccine is effective. So even though you're seeing that breakthrough, we keep emphasizing the importance of vaccine. Is it true that a booster shot will affect getting pregnant? That has not been shown to be the case at all. We have a lot of individuals who have become pregnant during this pandemic after they have been vaccinated. We also have really good studies now that there's a fairly high risk of serious disease in pregnant women. And right now, we're even recommending that pregnant women get vaccinated while they are still pregnant. So there has been no information, and our experience are showing no problems with fertility and no harm to the baby if you get vaccinated while you're pregnant. Some are saying that Omicron will help get us out of this pandemic, helping us towards herd immunity. When do you think actual herd immunity will be a thing? And given the history of other pandemics and their trends, what are you predicting? Dan, I'm going to let you answer that one.
Well, my initial response is I've stopped making predictions because, and I think most epidemiologists have as well, this pandemic has really changed many of our thoughts and expectations about how respiratory viruses can behave. And so it is very hard to predict what will happen and how soon we will reach what people are calling an endemic state. But I will say that every wave that happens does bring us closer to that period of time where when we see SARS-CoV-2 infections, they will likely be less severe and cause less disruption to the healthcare system and to the economy because more of the population will have been exposed both to vaccination, which is the preferable way to get immunity, and to the virus itself. So I do think that Omicron, once this wave goes past, there will be a period of lower community incidence. But remember that our immunity to this SARS-CoV-2 and to other coronaviruses does wane slightly over time. So there will be opportunities for this virus to continue to spread in our populations. But what we hope will happen, and if I had to guess, I would say sometime within the next year, is that when we see these peaks, they will be far lower, and we will begin to adjust to this respiratory virus, much like we've adjusted to other seasonal respiratory viruses, where it will still continue to cause disease and cause problems, but not on the scale that it is currently doing.
Here's a good question. As steep as this current curve is, do you foresee it dropping quickly as well? Do we have any predictions on when it will peak in Iowa? Dan?
Yeah, so I think that the case numbers are going to be peaking nationally over the next week or so. I think in Iowa, it arrived in Iowa in the Midwest a week or so, or maybe even closer to 2 weeks later than other parts of the country. And the other problem in Iowa and some other states is that we have lower overall vaccination rates. So there are more avenues for easy transmission for the virus in Iowa than in some other areas. So I think that the decline will be relatively rapid, but I'm not sure that it will be as rapid in Iowa as it currently is, for example, in New York State.
Here's a good question. Are people able to get the same variant multiple times? And I'll answer that. You know, one of the things that we have been able to watch, we now have been able to watch people's antibody titers over the course of, almost 2 years, is that the antibody titers are dropping over time. And that puts you at risk of getting a repeated infection. And that's why we recommended the booster shot 5 months after the first vaccinations, as we were watching the antibody titers drop. So you can get even the same variant multiple times. We don't think it will be as severe if you've been vaccinated or even if you've had natural infection, because your immune system has several different methods of remembering the SARS coronavirus and kind of mounting a really quick response that help truncate the infection. You still get it, but it's not as severe. The second part of that question is, what's the method that the Omicron variant enters the cells? We know that this variant has a lot of mutations on the spike protein, That spike protein is the really important part of the virus that helps bind to human cells. Interestingly, the Omicron mutations that we are seeing help the virus bind better to the human cells. And that's why we're seeing it being more infectious, and it can get into the cells and replicate faster. So that was one of the tricks that the SARS coronavirus chose to play on us, which was making a mutation that actually helped it bind the cells. It still does it the same way that all the previous variants did. It still gets into the same cells with the same receptor on the cells, but it just is doing it a little bit better, unfortunately. One of the questions, and this is a really important one, they're asking, can you explain what titers are? And that's a really important question that, I think we end up slipping into jargon. And so thank you for calling us out on that. When you make antibodies, we have a way of measuring them in your blood. And we look at the numbers of antibodies that are in your blood. Titers are simply a way of measuring them. And the higher titer you have, that means the more antibodies you have. And so we know that after you've gotten those 2 doses of vaccine, you form a lot of antibodies, a lot more antibodies than after 1 dose. What we see with that booster dose 5 months later is the number of antibodies are even higher than what we saw after 2 doses. If you look at people who have had natural infection, we know that if they get vaccinated after natural infection, they form more antibodies than they got after natural infection. More is better. So keep that in mind. And that's why we have very much recommended, even if you've had natural infection, that you do get the vaccine, because it improves your antibodies, the numbers, and it improves the quality of the antibodies. They actually work better. So that's an important thing to remember. Here's a good question. The first vaccine, Pfizer, that everyone continues to get was designed from the first variant. How effective is it for someone to get this vaccine now? So Dan showed you the data from California, the Kaiser Permanente study that was showing the efficacy of the vaccine. That was for the Pfizer vaccine, and that was the original Pfizer vaccine. So we are finding that the original vaccine is still really effective. It's not as effective as it was against the original strain that it was created against, but it's still really effective at preventing disease and very effective at preventing hospitalizations. Here's do we have any data on long COVID? Are there underlying risk factors in people who develop long COVID? Has the likelihood of developing symptoms of long COVID changed at all with the vaccines and boosters as compared to before? I can answer this one. I was just looking at this data earlier this week, and there is data that you can get long COVID symptoms even if you've had previous infection and now you get Omicron, or you've had vaccination, you get Omicron. But the likelihood is much less, at least 50% less. So it's another reason why we do very much recommend that people get their vaccine and boosters. It reduces that long COVID risk. And people are still finding themselves to have a lot of lingering symptoms, even for those that had the infection a year or 2 years ago. So it is not something to kind of dismiss. And I don't think, Dan, I'll speak for you, I don't think either of us recommend going out and trying to expose yourself and just get it over with. There's still a lot of transmission. There are people who are at high risk. We are still seeing hospitals that are getting overwhelmed. We need to get the curve squelched again, bring the curve down, help the hospitals stay open and able to care for people who have other illnesses, and prevent yourself from getting things like long COVID. If we got our boosters in September, do we need a second booster to help prevent severe COVID from Omicron? You know, that's something we can't answer 100% yet. The studies are ongoing. Israel has a study that's ongoing where they have given people a fourth dose. I can tell you that some of the companies here in the United States, Pfizer and Moderna, are also gearing up to test a fourth dose. And they have vaccines that are now targeted directly to Omicron. So we'll be learning about that. I do want to emphasize, even though we see the immune response lessening over time, there's still a lot of protection, even months and years later. As I said, there are many different layers of the immune system that are activated with the vaccine. And a lot of those have a long memory. So that's a good reason to be hopeful that maybe, you know, we aren't going to have to get vaccinated every 5 months until we get through this pandemic. If I've been boosted and vaccinated and recently got COVID, so likely Omicron, am I safer to do activities like eat out? Dan, you're an epidemiologist. What do you recommend?
So I still recommend that during this wave of Omicron and whenever community transmission rates are high, that you practice prevention measures, including avoiding crowded public places and wearing your mask when you're out in public. You know, having said that, are you at lower risk for infection immediately after an infection? Yes, you are. And we know that reinfection rates in the first at least 3 to 6 months after your infection are quite low. However, we have certainly seen with Omicron that because it can evade some of the immunity induced by prior infection with other variants like Delta, seems to be much more likely to cause reinfection than prior variants. Now, what we don't yet have enough data on is what about reinfection after Omicron infection with Omicron? We really are not far enough into the Omicron wave to really know about that. But I believe that you would have significant protection against repeat infection within the first 3 to 6 months after you've been infected. But I still, during the this current wave, would still practice precautions and remember that we're also in the midst of respiratory virus season. Influenza is also circulating, as are other respiratory viruses in the community.
This is a hard question. Should people get a booster if they've recently tested positive for COVID? Now, I haven't seen any recommendations from CDC, and so I can give you my opinion, which is based on knowing kind of the immune responses. And Dan can weigh in on this one too, because this is one where there isn't really good data. I think if you have had the vaccine and then you have gotten recent COVID-19, probably the Omicron variant, your immune system has been boosted a little bit with the infection. I think you could wait, maybe a month or two and then get your booster. It is not harmful to be safer and get boosted sooner than that. But I think you've kind of use natural infection to boost yourself a little bit. But Dan, you want to weigh in on that one? That's a tough one.
Yeah, and I think in part because, we don't have, a lot of really firm data to guide us. The CDC will say that if you are recovering from COVID and you are also due for a vaccine dose, that you should simply wait until you're completely recovered, wait until you feel back to normal, and then go ahead and get that dose of vaccine. And I think that would hold whether it's dose number 2 or whether it's your booster dose.
Do you think students returning to campus will elongate this peak of Omicron? Dan?
I think that's a great question and a valid concern. So we do, most of our attention has been focused within UI healthcare, but I do have weekly meetings with campus health officer, Johnson County Public Health, and others. And everyone is very cognizant of the fact that with the students returning, there will be increased risk for transmission in Johnson County. So I know that there are plans on campus for increasing availability of high quality masks, of regular of tests as that can be done both on site, test kits that students can use, and also our testing sites, including one at Old Capitol Mall, which is very close for most students. And then there's obviously campaigns to try to emphasize the importance of taking precautions for the student body and staff. So I think it's a valid concern. We're obviously keenly interested in how the return of the students is going to impact our case rates in Iowa City and Johnson County.
Any recommendations regarding getting a different manufacturer's vaccine instead of continuing to get the same? I think there's a little bit of data for the Johnson & Johnson vaccine that if you boost with one of the messenger RNA vaccines, that the titers are a little bit better. There's less of an issue if you were starting with Pfizer or Moderna. So I think I would get the vaccine that you can get. My preference right now is the messenger RNA vaccines. The Johnson & Johnson vaccine did have a little bit more, not a lot, but they had some rare side effects, especially in young women. And we have not seen some of those side effects with the messenger RNAs. So I wouldn't worry as much about that. I would worry more about getting a booster when you need one. What would you say to a person who fears adverse allergic responses to the vaccine? One of the things that came out early, especially with the Pfizer vaccine, is they thought that there was an increased incidence of allergies. And after the vaccine was actually released into bigger numbers of people that got the vaccine, the numbers became very similar to what we see with any vaccine we have had previous to the COVID vaccines. And that's true for all of the vaccines, Pfizer, Moderna, Johnson & Johnson. What we know is if you have had a serious allergic reaction to a vaccine, the allergy clinic will be more than happy to work with you, and they will work with you, talk through your history, and they will be willing to administer the vaccine under very supervised circumstances where they are very well versed in how to manage an allergic reaction. If you simply have an allergy to eggs or peanuts or other things like that, there is no increased incidence that we have seen with an allergy to these different vaccines. But we do have some great physicians that will work with you if you have a history and you're worried about that. So the allergy clinic is there to help. Can you touch on the data for pediatric infections, specifically the age groups that are not eligible for the vaccine? Are those age groups seeing more severe infections? What do we know about vaccine eligibility for kids under 5? Dan, why don't you talk about what we've been seeing here in the Stead Family Children's Hospital and what's showing around the country?
Yeah, I'd be happy to. And I think in the future, we'll want to get one of our pediatric infectious disease specialists here to talk in more detail. But I think the way that I'm seeing the data right now is that even though on a population level, the sense has been that children are at low risk for complications of COVID-19, they are not at no risk. And when COVID-19 spreads as widely and as rapidly in children as it has been with this Omicron wave, we have seen increasing rates of hospitalization. We've seen increasing numbers of children with COVID-19 in the Stead Family Children's Hospital. So it is, in my opinion, extremely important for us to see vaccine availability for children under 5. Not only will it prevent, these complications that might require children to be hospitalized or to develop longer-term symptoms, as Pat just mentioned around long COVID, but also having children having high rates of infection and unable to be vaccinated increases the spread in households and then from households into the community. So I think there are several reasons for us to continue to take precautions at schools, preschools, and also to expand the availability of vaccines. The timeline for the, I believe the 2 to 5 age group shouldn't be too much longer. I think Pat can maybe fill us in on that, but I think FDA approval might be fairly soon for that age group.
Yeah, I've heard that too. I mean, I did mostly in the lay press, like many of us get our first glimpses of what's to come by reading the New York Times or some of the other news outlets. They seem to be getting good info. The little kids, those under the age of 5, the reason that the vaccine has taken longer to get approved is we always test vaccines very sequentially. We start with adults and then move down to teenagers and then younger kids. So the timing makes sense. We do that to protect the youngest kids. The data that we got, though, from the young kids under the age of 5 is that 2 doses is not going to be enough. And people might say, well, that means that the vaccine doesn't work very well. And that's not true. We know that little kids, their immune system's a little less mature. And oftentimes it takes extra doses to generate the proper protective immune response. And we see that with many other vaccines. So I'm not surprised that they're going to need 3 doses. And I think from what we're seeing is they're hoping that they're going to get that data for perhaps the 2 to 4-year-olds in the next month and a half, and then they'll go down to the under 2. But it looks like there's another question that follows is, how long, we haven't had these vaccines long enough to know that they're really safe. And that's going to be particularly worrisome for some of you as we're starting to recommend vaccinating children. And I can tell you that, we now have seen people for over 2 years with this vaccine. We have not seen any late side effects at all. We have more data on this vaccine than we have ever had on any previously FDA approved vaccines in this shorter period of time. I am very comfortable. We have great animal data, nothing showing up that's worrisome, nothing showing up late in the adults that have gotten it. We also know the science behind this vaccine, how this vaccine works. There aren't particles that are going to be long-lived that last forever. And so I am very comfortable, and I think this is a very safe vaccine, and it will be very safe for the young babies as well. They may need more doses. Well, time will tell. If a vaccinated person catches COVID-19 and has no comorbidities, would you recommend they get booster shots? The answer is yes. Again, this was the question of timing. You are safe to get it as soon as you have recovered from your symptoms. You might wait a month or two, just let your antibody titers come down a little bit, give you a little bit longer protection, but that's a guesstimate. There's the recommendation, as Dan said, is when you're due for your booster, when you're due for your vaccine, go get it. Dan, why don't we dispose of masks in biohazard bins?
Yeah, that's a good question too. They're all good questions. I should stop saying that. The answer is that this virus, and I mentioned earlier that early on when this virus emerged, we sort of had to behave as if it had multiple different transmission routes. Droplet transmission, some aerosol transmission, direct contact transmission from surfaces to hands and what we've learned over the course of the last 2 years is that the predominant way that it's transmitted is via respiratory aerosols, and it does not survive very long in the ambient environment, exposed to UV light, other things. And so if you remove your mask and put it in the garbage and are practicing good hand hygiene, there does not appear to be any significant risk of transmission of that, of any contamination on the mask to another person. It really is mostly only really efficiently transmitted when it is inhaled. And that's via a respiratory aerosol. So that's really the transmission mode that we're focusing on most intently.
There's some really good related questions. One is, how long does the COVID virus survive without a living host? So if you had droplets that fell on your table or something, how long do they live?
Yeah. So this all depends on the environmental conditions. And if you want to Google it and spend a few days, you can learn that in some studies, it might last 12 hours on a surface if it's not being exposed to UV light, and if there is adequate humidity levels, et cetera, et cetera. In other circumstances, it will last, no more than an hour or two, or even less. On surfaces, the other, positive thing is that this is not a difficult virus to inactivate with soaps and disinfectants, just standard, things that we use. We don't need anything special like bleach to disinfect things to eradicate this virus. And then if it's suspended in the air, the survival depends almost entirely on how well ventilated the space is in which it is suspended, and whether that's an indoor space, an outdoor space, the temperature, the humidity, all of these things play a role. But the virus tends to lose its ability to cause infection over long distances, and if it is in a well-ventilated space. The circumstances where we tend to see highest risk of what we call the super spread events, or situations where that you've read about, like church services or weddings or funerals, or areas or situations where multiple people get infected at one time, that in general, those tend to occur in closed indoor spaces where aerosols can accumulate over time. And in that kind of environment, the virus can linger in the air for longer periods of time and cause infections over longer distances. So that's why we advise people to avoid those types of environments when we have high levels of viral transmission in the community. I'm rambling a little, so I don't know if I exactly answered that question, but you can tell me if I did.
Yeah, no, I think the big picture is mostly it's aerosol transmission. It's not so much on surfaces. There's a question here, how important is it to sanitize phones and doorknobs? And that's kind of related. You know, this is not the primary way that you get COVID-19. I would put your efforts more on wearing masks and avoiding large crowds. Some of those types of kind of protection methods, if you put your attention on those, are going to have a much more impactful prevention for you.
Yeah, and I think on that note, it's important to remember that, as you mentioned earlier, Pat, that how this virus adheres to our epithelial cells. The virus has to find a respiratory epithelial cell in a high enough amount to cause infection. So having the virus merely be on a surface and to come into contact with your skin is not enough to cause a COVID-19 infection. And as I said, that we've really learned that kind of surface contamination type of spread, some people call it fomite spread or direct contact spread, is a very minor mode of transmission for this virus. Still important to clean surfaces, to do good hand washing is key, but the focus really should be on preventing the aerosol route of transmission.
What's the data regarding treatments for COVID-19? That's a really good one. So we've been hearing lots about that. Do you want to talk about that, Dan?
Yeah, I think there's two parts to that. I think the treatment of those who are sick enough to require hospitalization has really advanced over the course of the pandemic. And so there are now like really well tried and true algorithms for the treatment of those who have to be hospitalized. And some of those treatments are simple and just include supplemental oxygen, but also steroids and other types of drugs that have particular effects on particular parts of the immune system that can help to prevent the further complications from your immune response to the SARS-CoV-2 virus. So those treatments are very effective, and as many of you already know, the mortality rates among those who do need to be hospitalized have come down quite a lot. Tragically, we're still seeing people die of COVID-19. It's just less frequent now with those treatments. Where a lot of the recent action are on treatments that can be given early during early symptoms of infection in those who are at high risk of progressing and needing to be hospitalized in an effort to curb that infection before it requires hospitalization. And for those, those advances, which are now becoming available just really within the last week or two, include one of the monoclonal antibodies. Some of the previously used monoclonal antibodies do not work well against Omicron. So there is one remaining that does work well. And then some oral therapies that are just coming out that also are very effective at keeping those who do get infected from having to be hospitalized. And we are starting to be able to administer those, which are easier to administer because they're in pill form. And those can reduce the risk of hospitalization for at least one of those medications, up to 80 to 90%. So we're very encouraged by those therapies. What we need, though, is wider availability. Right now, we're having to reserve those drugs for those patients who are at greatest risk of progressing and needing hospitalization while we have such a limited supply. And then the last thing I'll mention is there's also a combination of antibodies that can be given for those who have very compromised immune systems, whether from transplantation or cancer chemotherapy, et cetera, where it impacts your ability to mount a response to the vaccination. What this medicine does is it gives you the antibodies directly, and they stay in your system for several months as an alternative to, or actually as an adjunct to the vaccine to protect those who are most vulnerable because of the compromise to their immune system.
I think there's one thing that people should really take away is we do have some new therapies for people who are infected, but they are very scarce. And we know with a lot of other antiviral medications and stuff that they're not perfect. And so we've heard some people, it's like, well, I don't want the vaccine. I will just get the disease and then I'll get the therapies. We don't have many doses of those medications. They are good, not perfect. We still think the best strategy is to prevent yourself from getting infected. And the best strategy for that is vaccines and boosters. Here's a question about how does the COVID-19 compare to chickenpox? When I was a kid, parents exposed us to build immunity. My kids then were vaccinated against it. How many active cases of chickenpox have declined in the past 2 decades thanks to the vaccine? And is it realistic to expect COVID to trend like that? So I think the chickenpox story is a really good one because early on, parents didn't think this was a severe enough disease to recommend that their kid get the chickenpox vaccine. Now it has been, used and people are very comfortable with using it. And we have seen significant declines in the cases of chickenpox. And just like chickenpox with COVID-19, the other thing that I think is a really important point is just because a lot of kids have a mild illness, you have to remember that some kids are getting really severely ill from this disease. We have kids in the Children's Hospital that have terrible cases of the inflammatory syndrome and are very sick on ventilators. That was the same story with chickenpox, and it finally has been that the parents are taking the chickenpox vaccine. We hope that the parents out there realize that COVID-19 can be a severe disease for their children, and we do recommend that they pursue vaccination for the kids. I understand diabetics are at higher risk for bad outcomes from COVID-19. Does this apply to those with type 2 also? And what internal systems are at specific risk? Dan, you want to take that?
Yes, so diabetes and oftentimes type 2 diabetes can sometimes also be associated with obesity, which is also another risk for progression of disease. So it's important for everyone to be vaccinated, but when anyone who has medical conditions that increase the risk for progression should, it's even more important not just to be fully vaccinated, but also to get that booster dose. And I'm cutting short my answer slightly because I'm getting messages that we're at time. And so for these and other questions, I did want to make sure people knew that there were a lot of COVID-related resources that are linked from the same page that you accessed this webcast. And I think we will certainly be planning future similar events. and perhaps included in that, I would myself like to hear from some of our local experts on long COVID, on pediatric COVID-19, and then additional ones on the importance of prevention.
And just for those of you that were enjoying the shout outs, as we conclude our question and answers, they will come back on and you can look for some of those kind of really nice messages for families, friends, and some of our healthcare workers. Thank you for joining us. Your questions were great. I hope that you learned from this, and we are always here to help work through the different questions you have. Thank you.
Thank you very much.